how it looks different in someone with Alzheimer's disease compared to Parkinson's disease. I'll also cover mild cognitive impairment, which is a level of cognitive impairment below the level of dementia. And I'll talk finally at the end, I'll explain a little bit more about what a neuropsychologist is briefly and the types of evaluations that I do. I also should mention that I do not have any financial disclosures, and the statements and opinions in this presentation are mine alone and do not reflect the opinions of my employer. So what is cognition or cognitive abilities? We can think about a computer. I think that can be a useful analogy when thinking about how our brain works. So with a computer, you have some input, processing of information, storage, like storage of programs, files, and output. So if we think about something that we do with our brains, like the ability to read a newspaper article, the words that we're reading, the content being the input, we process that information, we make sense of it. That's the processing part. Maybe we store a few ideas or facts to memory so that we can share them later. That's the storage part. Or the ability to understand what others are saying in conversation and communicate back with them. That involves multiple cognitive abilities. Or the ability to plan a dinner party. All of those examples that I've shared with you involve different cognitive abilities. So I want to next mention that cognition, we can think about it on a spectrum. So on one end of the spectrum, we have normal cognition or normal aging. And we know that there are cognitive changes and unfortunately some decline associated with normal aging. That is, our memory is not as good as we age. Folks commonly report more difficulties with their memory, misplacing things, more frequent difficulties coming up with words or names as part of the normal aging process. And at the other end of the spectrum, we have dementia, and I'll go into more detail later, but basically dementia is defined as significant cognitive impairments that are substantial enough that they interfere with someone's ability to independently manage their activities of daily living. And in between normal aging and dementia, we have mild cognitive impairment. That is, again, mild cognitive impairment is more mild or more subtle than dementia. There are some cognitive impairments, but individuals with mild cognitive impairment are generally still able to independently manage their activities of daily living for the most part. So next I'm going to cover I gave you a few examples a few slides ago, some different examples of cognitive abilities or how we use them in daily life. But now I want to get a little bit more specific and give you a better understanding of how neuropsychologists think about cognition, the different parts of cognition, and then we'll talk about cognitive impairment in Alzheimer's disease and Parkinson's disease. So I'll briefly run through this list and then I'll get into each of them in a little bit of detail in the next few slides. But generally, we think about cognition as being broken down into intellectual functioning, attention, information processing speed, learning and memory, visuospatial abilities, language abilities, and executive functioning. Attention is, quite simply put, our ability to focus on information, either focus on information in our environment, like something that we're reading or watching or listening to, or it can be more internal, focus on information that we're thinking about or trying to process in our mind. There are multiple components of attention. You may have heard of divided attention, which is just another term for multitasking, or our ability to alternate our attention between two different tasks. For example, our ability to make dinner while also talking to someone over the phone. We have to alternate our attention back and forth between those two tasks. Sustained attention being our ability to sustain our attention over a longer period of time, like to read an article or watch a movie. Information processing speed is what it sounds like. It's our ability to quickly process information and oftentimes generate a response in a timely manner. You may have heard of bradykinesia, which refers to slowness of movement that's seen in Parkinson's disease. We can also see slowness of thinking or decreased thinking speed and decreased ability to come up with responses quickly. We call that bradyphrenia in Parkinson's disease. Visuospatial processing is our ability to
talking about any age group here, you know.
Visual information that comes to the brain from
not normal if you're 60.
And make sense of that spatial information to do things like recognize objects, recognize people, make spatial judgments, like when we're driving or when we're trying to park a car.
I'm not good at that.
Language is divided into two major components: our ability to comprehend written or spoken language and our ability to produce written or spoken language. And finally, memory. So when neuropsychologists think about memory, we think about multiple different parts of memory. So the first part being our ability to take in new information and learn it and then store it into memory. Our ability to later freely recall that information. And then something called recognition. So even if we can't freely recall what we heard or what we read, can we recognize that information if we see it or hear it later? Or does cueing hints help us to retrieve that information? And finally, executive functioning. You may have heard of executive functioning if you know anything about attention deficit hyperactivity disorder. In that disorder, executive functioning is a common deficit. Executive functioning involves a complex assortment of abilities. I like to think of like an executive of a corporation. So what do? They're involved in planning what's going on at the company, organizing, making sure things stay organized, kind of monitoring what's going on, problem solving. So that is what executive functioning is like in our brains. It involves the ability to plan, organize, think flexibly about things, problem solve, monitor what we're doing, and then switch to another activity if something's more pressing or urgent. So I want to remind you again about this, this graphic that I showed you a little while ago. Again, now that we've gone over the different parts of cognition, remember that we can think of cognitive abilities or cognitive functioning as occurring on a spectrum. So on one end of the spectrum, we have normal aging or normal cognition. And again, normal aging is associated with some changes, some decline in things like our ability to process information quickly and our memory, our word retrieval. On the other end of the spectrum, we have dementia, which is substantial cognitive impairment that interferes with one's activities of daily living. And then in the middle, we have mild cognitive impairment, which is basically more mild impairments that don't interfere with someone's activities of daily living. So again, this is just kind of a summary. We can diagnose someone as having mild cognitive impairment when they show difficulties on cognitive tests that we give them the difficulties are much greater than what we would expect based on their age and their education, but they still can do things like manage transportation, finances, cooking, medications, all of those different activities they would do on a daily basis. We know that about 10 to 15% of individuals who are classified as having mild cognitive impairment will get worse and progress to dementia each year, but not everyone with mild cognitive impairment does get worse or progress to dementia. And this is probably because there are causes of cognitive impairment that are reversible or treatable. So in that category, we would include things like depression, sleep disorders, particularly untreated sleep apnea. Folks can have cognitive impairments associated with use of sedating medications or as a result of a thyroid disorder or vitamin deficiency. So not everyone with mild cognitive impairment gets worse or progresses to dementia. And again, dementia is more substantial cognitive impairments. There's significant interference in someone's activities of daily living. There is usually loss of ability to drive, loss of ability to independently manage one's finances, medications, appointments, and so forth because of the cognitive impairment. That is an important point because we know that sometimes sensory loss, motor changes can interfere. So someone can lose the ability to drive because of loss of vision, or they can lose the ability to drive because of a motor impairment and inability to respond quickly enough. Or they can have trouble managing their medications because of a motor impairment and they have trouble manipulating their pills. So they need some assistance with that. So again, in order to diagnose dementia, we need to see that the cognitive impairments are resulting in some significant impairment in their ability to do different tasks of daily living. I also want to point out that mild cognitive impairment and dementia are non-specific terms. That is, they don't refer to a particular cause. Parkinson's disease can cause mild cognitive impairment in some cases and even cause dementia sometimes. Alzheimer's disease is a different type of cause of mild cognitive impairment and dementia. There are also other causes that I'm not going to get into in this presentation, but things like stroke, vascular changes in the brain that can cause mild cognitive impairment and dementia. There are, remember, reversible, treatable causes of cognitive impairment that we reviewed, like depression or untreated sleep apnea. And then there are also other neurodegenerative diseases like frontotemporal dementia that I'm not going to review in this presentation. So Alzheimer's disease and Parkinson's disease, what do they have in common? Well, they're both brain diseases. They have different pathologies, and they affect different parts of the brain, particularly in the early and middle stages. Alzheimer's disease is much more common. Alzheimer's disease is the most common cause of dementia in older adults, that is, individuals over the age of 65. There are estimated approximately 6 million individuals currently living with Alzheimer's disease in the US, and in comparison, about 1 million individuals living with Parkinson's disease in the US. And Parkinson's disease, as I mentioned, can cause mild cognitive impairment and in some cases cause dementia. But there can also be other factors that result in cognitive impairments in folks with Parkinson's disease. For instance, depression, sleep disorders, and folks with Parkinson's disease can sometimes acquire other neurological conditions. Some of them will go on to develop Alzheimer's disease or stroke, vascular changes that cause cognitive difficulties. So what is the risk of cognitive impairment in Parkinson's disease? Well, these figures are very rough and they vary widely by study, but it's estimated that approximately 40% of individuals with Parkinson's disease develop mild cognitive impairment, and approximately 20 to 30% will develop dementia. There are a number of risk factors that we know can contribute to someone's risk of developing either mild cognitive impairment or dementia in Parkinson's disease, including older age, over the age of 70, later onset of Parkinson's disease, particularly over the age of 70, longer disease duration, more severe motor symptoms, lower education, co-occurring depression, and co-occurring, they have had like a stroke or other vascular changes in the brain. And now I want to give you an idea of what the different cognitive impairments or what mild cognitive impairment can look like in Parkinson's disease. So cognitive impairment in Parkinson's disease can include impairments in any of these areas. It doesn't necessarily have to be all of these that I've listed, but it's typically one or more. So we most commonly will see difficulties with complex attention, difficulties with like the multitasking or holding on to information in one's mind to manipulate it. Commonly see slowing of mental processing speed, difficulty getting words out quickly, difficulties with executive functioning and visuospatial functioning are also common. And finally, the memory difficulties that folks with mild cognitive impairment in Parkinson's disease tend to exhibit are more mild than the ones we typically see in Alzheimer's disease. So most commonly, we'll see some mild difficulties with learning and some mild retrieval difficulties after a delay, but typically those folks benefit a lot from what I mentioned before, like the cueing or the recognition. So if we read a list of words and then we ask someone 20, 30 minutes later to recall the words, typically they'll come up with some of the words, have trouble coming up with others that they learned. And then if we give them recognition or kind of hints, that often helps them to recall more of the words. That's the typical pattern that we would see. Individuals with Parkinson's disease who have mild cognitive impairment are at risk for developing dementia, but they do not necessarily develop dementia over time. And then Parkinson's disease dementia is when we see more significant cognitive impairments, usually cognitive impairments that are more severe and that occur in multiple of those areas that I mentioned on the previous slide. And we also need to see loss of independence for activities of daily living. Again, the more complex activities like driving, cooking, managing medications, appointments, and finances. And we need to see that that loss of independence is the result of the cognitive impairments and not just the result of motor symptoms associated with Parkinson's disease. So Alzheimer's disease, I'm going to switch gears now. It's not a normal part of aging, although we know that risk increases with advancing age. So approximately 10% of individuals 65 and older have Alzheimer's disease, and approximately a third of those 85 and older have Alzheimer's disease. Alzheimer's disease does result in progressive cognitive impairment over time. So folks do transition gradually over time from normal cognition to mild cognitive impairment and then to dementia. The greatest risk factor for Alzheimer's disease is older age, over the age of 65. We know that's the greatest risk factor. There are also genetic factors that have been identified that increase risk of developing Alzheimer's disease. Family history of Alzheimer's, particularly having a first-degree relative with Alzheimer's, increases one's risk. Having a stroke or other vascular changes in the brain increases risk. Depression and various lifestyle factors that include things like smoking and high blood pressure, poor diet, diabetes, low activity level. Those factors also increase risk of developing it. So mild cognitive impairment in Alzheimer's disease often looks different from the mild cognitive impairment we see in Parkinson's disease. In terms of what we don't see the types of like mental slowing that we typically see in Parkinson's disease. And we see a more severe, pronounced impairment in new learning and memory. So earlier I gave you that example about the word list. So in comparison, someone with Alzheimer's disease, after a 20-30 minute delay, may not remember any of the words that we read to them or presented to them. And when we give them hints or cueing recognition, they don't benefit from that cueing. They, they really have not been able to store the new information that we presented to them. Sometimes Alzheimer's disease can present a little bit differently. Sometimes it can present as primarily a visuospatial impairment or primarily a language impairment, substantial difficulties coming up with words, for example. Most commonly, though, we see really pronounced difficulties with new learning and memory, and then sometimes secondary difficulties with aspects of visuospatial and language abilities. And I would say that, dementia in Alzheimer's disease, we see, again, many of these same cognitive impairments. They are more substantial or more severe. And again, we see that loss of independence for activities of daily living, most commonly loss of the ability to independently manage things like one's finances and appointments and transportation and so forth. So I'm going to switch gears now that we've reviewed kind of the primary points that I wanted to hit for this presentation. We've talked about what is cognition, what are the different aspects of cognitive abilities, what is cognitive impairment, what is mild cognitive impairment, how is that different from dementia, and what are some of the risk factors, and how do these conditions, mild cognitive impairment and dementia, how do they present differently in Alzheimer's disease and Parkinson's disease? So for the end of my presentation, I want to talk a little bit about what is a neuropsychologist, what is it that I do, because I think most people don't know. So the most common question I get is, what is a neuropsychologist? We are not neurologists and we are not psychiatrists. Neurologists and psychiatrists are physicians who went to medical school, and they can order various medical tests like blood workup and brain scans. We don't do any of that. We don't prescribe medications or order medical tests. So neuropsychologists have a doctoral degree in clinical psychology, and we're licensed as psychologists. And we've completed a 2-year fellowship specializing in clinical neuropsychology after our doctoral degree. Primarily what we do is neuropsychological testing, that is testing of cognitive abilities as well as testing of things like emotional functioning and behavioral functioning. And some of us also do therapy. How do we measure cognition? How do we diagnose folks with mild cognitive impairment or dementia? So we have standardized tests that have been administered to healthy members of the population, individuals who vary by age and education and demographic background. So when a patient comes in for an evaluation and we administer them these various tests, we're able to compare them to individuals of their same age and their same education to understand, are they performing normally for what we would expect based on their age and education, or do they have any areas of difficulty or impairment? We classify scores as either being normal or impaired, or sometimes they're kind of in the gray area. We might refer to that as an area of weakness. We test all of those various aspects of cognitive abilities that I mentioned earlier, like attention and processing speed and memory and executive functioning. We also interview patients, family members, and give them questionnaires asking about other factors like mood, anxiety, sleep, because as I mentioned, we know that sometimes those factors which are treatable are contributing to cognitive difficulties. And finally, what is the purpose of neuropsychological testing? The purpose is to evaluate, again, for cognitive impairments versus normal aging. Sometimes patients come in with significant concerns about their memory, and they perform completely normal on testing. And so in those cases, we assume that what they're experiencing are some of those normal age-related changes that I mentioned earlier. We evaluate things like mood functioning, anxiety, and sleep, provide information about the likely cause or causes of someone's cognitive difficulties. We make recommendations like about safety, treatment, quality of life, mood, sleep, and so forth. Neuropsychological evaluations are sometimes used as a cognitive baseline. So if someone's neurologist suspects that they are having some cognitive difficulties or impairment, and they want a baseline to be able to track the person in the future, that's one way that these evaluations are sometimes used. And we also do pre and post DBS procedure neuropsychological evaluations. So that concludes my talk, and I look forward to seeing everyone virtually and answering your questions in a few weeks.
Hi, how are you?
Good. Hi, everyone.
Thank you for your presentation. That was fantastic. So I am just waiting to see if we have any questions in the chat. Give me a second.
I have a question.
Sure.
When should a person be evaluated for cognition? Should every Parkinson's patient be evaluated at a baseline, or?
That's a great question. So I would say that first, if the patient or the patient's, family members, caregivers have any concerns, they should raise those concerns with their neurologist. Neurologists can do short cognitive screening measures. So most commonly, I might see that if a patient is referred to me by someone's neurologist, maybe the neurologist has done a short cognitive screening measure with them first. Not everyone needs to have a neuropsychological evaluation, probably. In some cases, sometimes the question can be answered via short cognitive screening. And if there are further concerns or there's a question about multiple factors that could be contributing, like is this the effect of Parkinson's? Could this be the early stages of Alzheimer's? Could this be depression induced? Usually it's those cases where there's more complicated factors that we see patients who get referred to us for evaluations. But I would start with raising your concerns if you have any with your neurologist and see if they think a referral to us would be a good idea.
Could you talk a little bit more about sleep and cognition?
Sure. There can be multiple things, different types of sleep disorders that can impair cognition. So Dr. Pontone talked about the importance of getting at least 6 hours of sleep. We know that in folks who have insomnia, particularly when the insomnia is associated with sleep deprivation or short sleep attainment that is less than 6 hours, that we start to see cognitive impairments pretty quickly when folks are deprived of adequate sleep, most notably mental slowing, difficulty retrieving information, difficulties with attention. That's a common finding. Another factor that folks sometimes don't consider is sleep apnea. Sleep apnea is a major cause of treatable cognitive impairment. And sleep apnea can also cause problems with thinking clearly, with attention, and with memory. Unfortunately, sleep apnea is treatable, and we do see that folks show cognitive improvements pretty quickly after they're treated for sleep apnea. So common signs where we might suspect sleep apnea, that one's partner may notice heavy snoring, times during the night when the person stops breathing or maybe gasps for air. Folks with untreated sleep apnea also have a lot of daytime sleepiness. So they very easily nod off or are very sleepy during the day, despite having adequate, attainment of sleep in terms of number of hours at night.
Great, thank you. The next question I have is there a difference between cognitive decline or cognitive impairment, or are they the same?
Yeah, that's a good question. So typically we would think of them as being the same thing. I guess the only caveat for that is you could talk about normal age-related changes, I suppose, as reflecting cognitive decline, but most typically when we're talking about cognitive decline or cognitive impairment, we mean the same thing. We mean that someone is performing substantially below where we would expect based on their age and their education on objective cognitive tests.
Okay, great. The next question I have is, are there exercises that can help improve cognition?
So there are a number of things, lifestyle changes that we know can help improve cognition. Dr. Pontone talked about them during his talk. We know that getting regular physical exercise results in cognitive improvements, particularly aerobic physical exercise. We also know that being more mentally and socially engaged, more socially active, and involved in mentally stimulating activities can help to improve cognition. So there's not necessarily one thing that I would point out. There's not like one computer game that is going to do it more than another. Staying mentally active, staying socially active is going to look different for different people. Maybe someone really enjoys reading and participates in a local book club. That's staying mentally and socially active. I've had patients who are involved in like learning a new language or who decide that they want to pick up a musical instrument like the guitar. Those are other ways of challenging the brain and staying mentally active. Still others really enjoy doing word games on their phones. So there's no one thing that I would point to, but think about what you would be willing to do and what you might enjoy that would help to engage your brain mentally, socially, and then of course the physical activity.
Okay, great. So I have two more questions. What about craft activities, things that, help you work with fine motor skills?
Yeah, that's a great question. It's not something that I've thought about a lot. Certainly, I think doing crafts like engages parts of the brain involved in creativity, which could be very helpful. Sometimes crafts could also be done as part of like a social activity, right? Like a sewing group or something like that. So they could have that added benefit as well. Really the research shows that like the more activities you do and the more varied those activities, the better. So just staying home and playing word games on your phone is probably not the way to go. But if you add other activities to that, like, oh, I also enjoy playing tennis or going to the book club, in addition to playing word games or doing crafts, doing more activities that are varied in nature is probably the best approach.
Great, thank you. And the last question is, what about rhythmic exercises? Are they helpful? Like drumming?
Yeah, that's also a great question. I would say, anything that's musically inclined, that engages your brain. Probably the rhythmic component may also help with motor symptoms and so forth. You'd have to, ask your movement disorder specialist about that. I do also see a question in the chat about heredity. If one has a parent with Alzheimer's, are you more likely to get mild cognitive impairment, which could progress to Alzheimer's? So yes, we know that having one first-degree relative, that is a parent or sibling with Alzheimer's, does unfortunately increase your risk of developing Alzheimer's, mild cognitive impairment, as well as dementia. And having more than one first-degree relative increases it further. But remember, just because you have a parent who had Alzheimer's, it does not mean that you are bound to get Alzheimer's. We also need to think about other factors that increase risk, like lifestyle factors. So it may be the case that maybe your parent didn't have a very healthy lifestyle. Those are things that you can affect, right? You can quit smoking, you can change your diet, get more physically and mentally and socially active. So you're not bound to get Alzheimer's just because a parent had it.
Great, well, thank you so much. I don't think there are any other questions. So this does conclude our breakout session. Please return to the meyerberg.org/LWP page. We have posted a link. All right, well, thank you so much. This concludes our breakout session. Please return to the meyerberg.org/LWP page. We have posted a link to this page in the Zoom chat, and once on the page, you will be able to join the next session by clicking Join Session Now. So thank you so much for your time. This was great.
Thank you.
Bye. Thank you.
Thank you.